Good morning, everybody. It's a genuine pleasure to introduce my colleague and dear friend, Dr. Jennifer Olges, who will be giving today's grand rounds. Dr. Olges is an associate professor of medicine and currently serves as the director of our internal medicine residency training program. She was born and raised in Louisville and earned her bachelor's, master's in public health and medical degrees from the University of Kentucky, having graduated AOA. Dr. Olges is MedPeds trained and completed both residency and a chief residency at Loyola University Medical Center in Chicago. In addition to running our training program, she's a hospitalist here at UofL Hospital. Throughout her career, she's earned many accolades, both as a clinician and educator. She became a fellow of the American College of Physicians in 2018 and currently serves as the governor of our state chapter here in Kentucky. She's an expert in faculty development and in curriculum design. Over the last 3 years, she has been a co-developer of a curriculum to train internal medicine residents in implicit bias, healthcare disparities, and anti-racism. Please join me in welcoming Dr. Jennifer Olges for her presentation on bridging equity in academic medicine.
Thank you. All right, so I'm really excited to be here. I'm excited to be in this room. For those of you who are new to U of L since COVID, this is where we've traditionally always held our Department of Medicine grand rounds. And so this is the first one back in the auditorium since COVID. So I'm excited to be the first. Let's see. I think it went to sleep on me. Hang on. Maybe we'll just use the keyboard. Maybe. Nope.
Click enter and down arrow. Yeah, the three big points.
I'm clicking arrows.
Okay. Just so separate. Because it was working a minute ago.
Okay.
So double click.
Okay.
Is
it working now? Okay.
Yeah.
It was technical difficulties, you know.
All right.
Okay.
Yeah. So
Okay. Very good. Very good. Okay. So I have nothing financial to disclose, although I do want to address the elephant in the room. We're going to be talking about gender bias, but also racial bias today. And I recognize that I am a white woman. And I am by no means an expert in DEI, but as Dr. Smith mentioned, we have been building a curriculum of anti-racism and healthcare disparities. And I've really done a lot of sort of listening to experts over the past several years. And so, you know, I also recognize that I do have a considerable amount of personal privilege and power because of the color of my skin. And I think that's a reason why someone like me should be up here, because I think it is up to those of us who do have privilege to really work towards making the environment just and equitable for everyone. So today I'm going to define implicit bias and build a case for its impacts on medical education, as well as review some of the concrete ways that we can start to change that narrative. Specifically, we're going to talk about how to recognize and address microaggressions, as well as to discuss how to identify and mitigate our own biases in our evaluations and letters of recommendation. But before we begin, I think that every good grand rounds begins with a case. And so I wanted to introduce you to Jane. She is a Black female, and she is a second-year categorical resident here in internal medicine. And she is interested in pursuing subspecialty fellowship training once she graduates. So I want you to keep her in mind as we go through this talk, and we'll come back to her from time to time. Before we can talk about implicit bias, we have to talk about the brain and how it operates and processes information. Over the past 30 to 40 years, psychologists have described cognition as dual processing, made up of two separate systems, System 1 and System 2. Daniel Kahneman wrote about this in his book, Thinking Fast and Slow. So system one thinking is that rapid, instinctive, automatic behavior. It's pattern recognition. So think about simple arithmetic. If you saw 2 + 2, you would immediately know it's 4 without putting any real intentional thought into it. When you drive to and from work, once you move to the city and you get familiar with it, you really, a lot of times you're driving on autopilot. And I don't know how many people in this room have gotten home and thought, I don't really remember the details of my ride home, because you don't have to actively think about it. Our fight or flight response is system one thinking. If you got home today, walked into your kitchen and saw a tiger, your immediate response would be to close the door. You wouldn't have to think, maybe I should close the door. So a lot of what we do in medicine is actually system one thinking. We make a lot of decisions without really actively having to consciously think about things. It's your doorway exam. When you walk into a patient's room and you know immediately whether they're sick or not sick. It's the pattern recognition and really kind of making clinical decisions and helping you to reason through what's going on with the patient. So contrast that with the system two processing, which is that active, deliberate, slower, more conscious thinking. And so that would be something more like advanced mathematics. If I asked you to multiply 297 by 4,384, you'd have to think about it. You wouldn't be able to instantly come up with that answer, or most people would not be able to. So much of our thinking is system one thinking. And I think it's a good thing. That's why our brains are designed that way, because otherwise you would be completely overloaded if you had to actively think about every single thing and every single decision you make. So implicit bias or unconscious bias is a type of system one thinking. It refers to the attitudes or stereotypes that we all hold about groups without our conscious awareness. They're automatic, they're unintentional, but they do impact our judgment, our decisions, and our behaviors. So it's important to keep in mind, everyone in this room, all of us have biases and unconscious thoughts, unconscious biases. It's equally important to keep in mind that sometimes those unconscious biases are counter to our conscious beliefs. So I hope that everyone in here is thinking to themselves, I am not sexist, I am not racist, I believe that everyone should be treated equally, deserves to be equal and all of that. But I think sometimes our unconscious thoughts view the world differently than our conscious beliefs are. And I think if we have to recognize that, because it absolutely does impact our decision making. So our unconscious or implicit bias begins to form early in our life, and it's shaped by our environment and who we're surrounded by, what we're exposed to. So it comes from our parents and our families, our communities, our organizations that we belong to, our schools. Another big entity that shapes our thoughts and our unconscious bias is the media and how people are portrayed in television shows and movies, in books, in magazines, and advertisements. And so the next few slides, I want to show you some examples of real life things that, kind of characterize how we can develop these unconscious biases. So this is a worksheet from a website that teaches English as a second language. And you'll notice that the professionals on here, the doctor, the dentist, the veterinarian, the lawyer, the engineer, they're all men. And you'll notice that the nurse, the teacher, the secretary are women. If you are keen-eyed and can see well, you might also recognize that there's only one African-American character on this slide, and it's the prisoner who is being escorted away in handcuffs. And so this sends a very powerful message to someone who's viewing it. This is another example from a children's workbook. And if you notice the positive words, happy, proud, those are characterized by white characters. And then the negative words, sad and angry, are characterized by Black or brown characters. So these are two pictures that were taken right after Hurricane Katrina. And if you notice, the caption for the top photo mentions that this person is looting. And the caption for the image at the bottom says that they're finding food. And my last example is how the media sometimes portrays people who have been arrested and charged with crimes. And so the top image are 3 clean-cut young white men who were charged with burglary. And the bottom is 4 African-American males, mugshots, also charged with burglary. So I think this is not uncommon to see in the media. So I am not immune to implicit bias. And when I think about where I came from, my upbringing, it makes sense to me where it comes from. So I'm admitting my age a little bit, but I was born in the 1970s and I grew up in the 80s and early 90s here in Louisville, in an East End suburb, St. Matthews, for those of you who are familiar with Louisville. For those of you who are not familiar with Louisville, it has been and continues to be a very segregated city. There is a very clear racial and socioeconomic divide between the city, dividing the West End and the East End of the city. So I grew up on the East End. I am the product of Catholic school education from kindergarten through 12th grade. I lived in a very middle class, very white neighborhood. I can think of 3 non-white students who attended my K through 8 elementary school at some point when I was there. They weren't even in my class. They were there at some point during my education. When I went to high school, there were a handful more people who were non-white, but really not many. I also grew up in a very traditional household. My father worked and my mother quit her job as a teacher when we were born to stay at home with us. So I've taken some of the Harvard implicit bias tests, and I encourage you to look these up if you've not done one before. Now, I know that they're not without controversy, but I do think it gives you a little glimpse into what your unconscious biases might be. And so for me, although I am a strong female physician, very accomplished, who is a program director and really works towards gender and racial equity, I have a strong association toward men and careers and women in home. I also have a moderate preference for white over Black, for straight over gay, and a slight preference for young over old when I do my implicit bias testing. And again, I think it makes sense when you think about my upbringing and what I was exposed to for the first half of my life, being very homogenous and very traditional. It makes sense that that's where my unconscious biases formed. So the unconscious biases that we have been shown to impact the care that we provide to patients. And there's a lot of evidence on this. I just wanted to point out a few. It's well documented that we undertreat pain in Black patients as well as Latino patients. Additionally, Black patients tend to be less likely to receive evidence-based care for their cardiac disease or CVA, or they're less likely to be referred for renal transplant. And there are a lot of reasons for this, but when they've looked at it, some of the reasons are because the physicians believe that they're less likely to be adherent to their medication, or they're less likely to follow up in clinic. It's not just race that we have bias against, it's also age and gender. And so there was a study that showed that we're less likely to treat suicidal ideation in patients who are of advanced age. And women are also less likely to receive the same type of care that men do, and evidence-based care, specifically cardiac disease. I've also seen studies have looked at COPD and diagnosis as well. So not only does implicit bias impact the care that we provide to patients, but it also impacts our profession as a whole. And so I want to go through some of the evidence of why I say that. So there was a study published in JAMA in 2017 that looked at racial disparities in membership of AOA. And it looked at 4,500 students who were reviewed for AOA and found that white students were 6 times more likely to be invited to AOA compared to Black students. And students of Asian descent were 2 times more likely to be invited to AOA compared to Black students. And that was after controlling for step 1 scores. And then white students, again, were more likely to be invited over non-white students, even after controlling for membership in the Gold Humanism Medical Society, as well as hours of community service. There's also an article published in the Journal of Public Health in 2012 that looked at faculty promotion rates and found, again, disparities in promotion rates based on race. And so specifically between 1983 and 2000, promotion rates for Black professors was less. So specifically for Black assistant professors going up for promotion to associate professor, about 19% were promoted versus 30% of white professors or assistant professors. And then 17% of Black associate professors were promoted to professor compared to 31.5% of white associate professors. And lastly, there was a study published in the journal Science that showed that Black and Latino researchers were at least 10 percentage points less likely than white researchers to be awarded research grants from NIH, even after controlling for things like educational background, previous research awards, and publication record. Bias also influences who becomes doctors and really disadvantages some who are underrepresented in medicine. So although Black or African American people make up about 13% of the population, they only account for about 5% of physicians. And in 2018, only about 2.6% of doctors were Black men. And that was actually decreased compared to what it was in 1940. And so there are a lot of factors that go into that, and we could have a whole grand rounds just about that. But at least some of it may come down to bias among admissions committees. And so there was a study that was published in Academic Medicine in 2017, where the researchers did implicit bias testing of all of their admissions committee members at Ohio State. And they found, very similar to my findings, that the majority had negative unconscious association with images of Black people and homosexual people, and were more likely to associate men with careers and women with homemakers. So racial bias isn't the only thing we see. We see gender bias as well in our profession. We still see large differences in income between male and female physicians, even after accounting for gender differences in specialty choice, hours worked, family structure, marital status, and years of experience. So the Journal of Health Affairs estimated that female physicians earn $2 million less than their male counterparts over the course of their career, even when controlling for things like specialty choice and hours worked. And in the study, one of the things that they found was that male physicians tend to get paid more in their first job out of training. And that has a cumulative effect over the course of one's career. This will come as no surprise to many of the women in this room, but female physicians are sometimes less likely to be referred to by their title. compared to their male counterparts. And so there was a study that was published in the Journal of Women's Health in 2017 that reviewed how speakers were introduced at grand rounds for internal medicine at 2 different institutions. And they demonstrated that women were less likely to be called by their title. Specifically, male speakers introduced other males when male speakers or male people introduced other males, they used their title 71% of the time. And for females, it was only 47% of the time. So now that we recognize, and hopefully you see that there is some evidence that this exists, what can we do about it? So the first thing I want to talk about are microaggressions and how to recognize those and how to act and speak up when you encounter a microaggression. So what is a microaggression? It is an everyday slight, insult, or snub that often happens casually, without intention of harm, sometimes without any clue by the person who is saying it that it's not good, but it sends it communicates a hostile, derogatory, or negative message to the recipient. And oftentimes it's based on race or gender, ethnicity, sexual orientation. And so even though the intent by the person who makes the comment is not to cause harm, the impact that that can have on the person receiving it can be devastating, especially if they receive multiple microaggressions on a daily basis. It's really death by 1,000 paper cuts. So I wanted to share a couple of examples of what this looks like. So my husband is of South Asian descent. He's a first-generation American, and he is a physician here in town. And he, every day in clinic, at least one patient will say to him, "Well, doc, where are you from?" And he says, "I'm from California." No. Where are you really from? Or, sometimes you'll have somebody who has a name that's not your traditional sort of European name, and you'll hear patients or others say, "I'm never going to be able to pronounce your name. I'm just going to call you Dr. S, or I'm just going to call you by your first name." And so what that conveys, even though it's probably well intended, it conveys to the person hearing it, "You're an outsider. You don't belong." Or, "Oh, you speak English so well," or "That speaker was so articulate." And especially when it is stated when it's somebody who is either from, Black, African American, Latino, Asian descent. So that conveys the message, "You don't belong," or it's unusual for someone who looks like you to be intelligent. So assuming that the female who comes in and scrubs is a nurse, or calling exclusively the female residents or the female physicians by their first name is conveying a message, women aren't doctors, women can't be doctors, or it's unusual for women to successfully become doctors. Or assuming that the Black person in scrubs is patient transport or housekeeping, again, conveys that message that being a Black doctor is unusual. Describing an assertive woman as bossy, that's really saying women aren't qualified to be in positions of power or leadership. I've heard this stated in this institution before, and I think it was said to a trainee really to try to make them feel less stressed, but, "Oh, don't worry, you'll get in because of your gender or your race." And again, I don't think it was said with any malintent, but the impact of that was saying, you can't get in on your own merits. And the last one, and I know I Zoom challenge, but it's, crossing the street when you see someone who's Black or Latino walking towards you or clutching your purse a little bit tighter, really is conveying a message to that person that, "I think you're dangerous." So learners definitely experience microaggressions during their training, and sometimes on a daily basis. And so let's get back to Jane. So she is rotating with you on your inpatient service. And she is, one of the patients she's caring for is Mr. Smith. He is, admitted to the hospital, and she pre-rounded on him this morning. And so the two of you get together to round, and you go into the room together, and he takes one look at you and he says, "Oh, good. Now you are my kind of doctor." So if you were faced with this scenario, what would you do? How would you respond? Would you say something in the moment? Would you think about it, say something later? Would you ignore it and just not say anything at all? Well, hopefully after today's talk, you will feel comfortable and competent and be an upstander and respond in the moment. And so an upstander is someone who intervenes on behalf of a person who's being attacked or bullied. And I want to point out, we call them upstanders and not bystanders, because sometimes bystanders watch what's happening but don't intervene. So think about a car accident, and a lot of people might be standing around watching, and only a few people are actually trying to help the person. And it's not because they don't care. Sometimes you just don't know what to do. And so you sort of stand there frozen. And so just like ACLS and BLS helps us to be able to respond to emergencies, thinking about how you would respond to microaggressions and doing upstander training can really help prepare you to be able to address microaggressions in real time. And so it's not easy to be an upstander, but I think hopefully today I will be able to give you a few phrases that you can put in your pocket that you can use when you encounter a microaggression. So there are a lot of mnemonics to help remember how to do this. I like the erase mnemonic, but you don't really have to even remember that so much, but want to go through sort of the steps. So one, for E, expect that it's going to happen. When you are in the clinic or on service or anywhere you are going to encounter microaggressions. And so I think you need to be prepared for it. I think traditionally the most senior person in the room probably should be the one speaking up, because I think that, a student or a resident is not going to feel comfortable defending themselves or speaking up maybe to an attending. And so again, if you're the most senior person in the room and you encounter a microaggression, it's on you to be the one to speak up. Definitely should not be the person who is the victim of the microaggression. We don't want to put that added burden on them. R stands for recognizing the mistreatment, and it can be difficult if you're not actively paying attention for it. If you are just sort of going about your business and not really thinking about it, you might miss them, because sometimes it's subtle. Sometimes it's stereotypes. Sometimes it's just the colloquialisms that we use in our language that we don't even think about. A stands for addressing the situation in real time. So I'm going to provide you again with some approaches that you can use, but before I do, a couple of caveats. So one, you need to make sure that it's safe for your team. And so if you've got a patient who's threatening, probably you're not going to try to address the microaggression with that patient. You need to get your team out safely. Likewise, if it's a completely demented or clearly delirious patient, it may be better to redirect rather than actually try to address the microaggression. S is for supporting the target of the microaggression. And so once you've addressed it in real time, as soon as you leave the room, you need to debrief. You need to check in with that learner or the person who was the target and find out what you can do to support them. So you might say something like, I was uncomfortable with what the patient was saying, and I want you to know that wasn't okay. I'm really sorry that happened. How are you doing? And what can I do to help to support you? You might need to escalate to the program leadership, to a chief resident. You might need to escalate to even security, depending upon what is taken place. We had a situation several years ago where a trainee was called a racial slur by a patient, and it was so egregious for her. We actually pulled her off service for the day because she couldn't continue to see patients, and we needed to make sure that she was okay. And then E is establishing and encouraging a positive culture. So if all of us speak out when we hear microaggressions and defend the person who is being kind of targeted, we're sending a message to our trainees that it's not okay, that we support them, that we want this to be a safe environment for everyone. We're sending a message to our patients and to the staff and to families that we don't tolerate that kind of talk. And I think that it really does work to improve the culture of the program. So as you're beginning to address it, you really have to remember that you want to focus on the behavior and not the individual, rather than telling somebody, oh, that was racist or you're racist. Better to approach it in a way of targeting the behavior and say, you know, you probably didn't mean to say it like this, but you know, this is how it came across. So as promised, some strategies that you can take away to be able to navigate these. So you might choose to ask an open-ended question. And these are really helpful because it allows the person who made the comment to self-reflect on what they've said and kind of draws attention to what they've said. So in this case, and this is like Jane, an African-American resident exits the patient's room as you, the white attending, enters. And the patient says, now you are my kind of doctor. And so asking an open-ended question, you might say, what do you mean by that? And it puts it back on them to really kind of reflect and sort of explain why they said it. And again, sometimes that can be a really good learning moment for the patient or the person who has said that to reflect on their words and how it matters. You might choose to label the behavior, label what you're seeing, and probe for clarity. So if you overhear a male resident in the workroom saying to a female medical student, would you go down to the cafeteria and get lunch for everybody? I mean, that seems like women's work, haha. So if you're going to label the behavior and probe for clarity, you might say, did I just hear you make a sexist remark to your medical student? You're not calling them sexist, but you're calling out the behavior. You might inject surprise, and this is really useful when you don't know what else to do. Maybe you're caught off guard by the microaggression and you totally blank and you don't know how to respond. This will buy you a little bit of time. It will kind of stop the conversation, give you a second to regroup, and also call it out. So you walk in, a patient says to you, the male attending, as you walk into the room behind a female resident, oh, good, glad you were here. I thought for a minute I was just going to get a lady doc. So you might say, ouch, I'm surprised to hear you, or I'm surprised to hear you say that. And you kind of stop the conversation for a second. And then hopefully you can regroup and think, you know what, you're really lucky that this is your doctor. She is one of our best residents, and I would trust her to take care of my family members. And so you're really supporting that learner and calling out the comment. You might need to be direct and call out your stance. So a patient tells a racist joke, and you might need to say, oops, I didn't mean to do that. I really don't find that funny. Or, you know, after sitting in a waiting room with a racially diverse group of people, a white patient walks up to you and says, you really do see all types here, don't you? And so your response might be, yes, and I love how diverse our patients are. You might need to make it a teachable moment and really make sure that that perpetrator understands that what they've said is not right or not appropriate. So a patient says to a resident who's wearing a turban, hey, what do you got up there? Or what are you hiding up there? Haha. And so you might say, you know, I suspect you meant no disrespect with that or meant no harm by that, but that was really disrespectful. And if all else fails, and especially if it's a truly egregious event like a racial slur, you might just need to invoke our institutional values And so if a patient refers to a resident using a racial slur, you would say, here at UofL, we treat everyone with respect, and we expect you to do the same. We don't tolerate that kind of speech here. Or if you overhear a nurse making an inappropriate joke about a patient, you might say, that's not really in line with what we expect in our hospital. We treat our patients here with respect. So because we all have implicit bias, we may find ourselves to be the perpetrator of a microaggression. And so if you recognize that you have said something that has been a microaggression towards someone else, take a moment, take a breath, acknowledge it and apologize for it, and then work to do better. So going back to Jane, again, you decide that you're going to address Mr. Smith with an open-ended question. And so you say to him, can you tell me what you meant by that? And so he may backpedal a little bit and say, well, it was just a joke, or I didn't mean it, but at least it calls out the behavior for the patient. It causes them to think about it. Maybe he won't say something like that again. It shows Jane that you acknowledged it and you're going to stand up for her, which is a big thing for her. And then afterwards, you take her aside after you leave the room and you debrief about it. And you tell her that you acknowledge that was not okay, and that you're sorry that happened, and what can you do to support her. Okay, so sticking with Jane for a second, the rotation has ended and the residency program sends you an evaluation to complete on Jane. And I know everyone here is going to fill out their evaluation. And she also emails you and asks you if you would be willing to write her letter of recommendation for her fellowship application. And so let's think about the types of words that you're going to use to describe her in your evaluation and your letter of recommendation. So unfortunately, our implicit biases can influence the evaluations that we complete on our trainees, as well as impact the words that we choose to describe them in our letters of recommendation. And this is true for women. It's true for groups who are underrepresented in medicine, such as Black, Latino, Indigenous groups. So one of the ways that the bias reveals itself is through the words that we use to describe the learners. And when you think about evaluations and letters of recommendation, and we describe physicians, the terms, the adjectives that we use really fall into two big buckets: agentic and communal. So agentic traits are those that pertain to self-assertion and independence. They're words like leader, persistent, ambitious, smart, assertive, clever, capable. So examples of this might be: John pairs his passion for research with an equal passion for clinical medicine. He is a leader on the wards and a role model at the bedside. Or his fund of knowledge and clinical judgment are outstanding. In addition, he is an outstanding leader of the team. He really functioned at the level of a resident. So contrast this with communal traits. Communal traits are those traits that pertain to concern for others and interpersonal skills. It includes words such as friendly, fair, honest, helpful, compassionate, empathetic, kind, patient. So an example of this might be: faculty members commented on the kindness and compassion Susan displayed, as well as a strong sense of teamwork and collaboration. Or she is calm and kind in the stressful CCU environment, very friendly and always there to help teach and care for patients. So research in this area shows that we are more likely to describe men, and particularly white men, using agentic traits, while we're more likely to use communal traits to describe women or even those who are underrepresented in medicine. And so I think that I'm not saying that we shouldn't strive as physicians to be compassionate and have that care for others. We want physicians who are honest and patient and kind and helpful and compassionate. And likewise, I'm not suggesting that we shouldn't ever use those terms in letters of recommendation or evaluations. But the agentic traits tend to convey an ability to be a leader and kind of conveys skills and talent. And so if we don't use those terms when we're referring to females, or we don't use those terms when we're talking about those who are underrepresented in medicine, we have the risk of sending a message that they're not quite as good at leadership, they're not quite as capable or competent as their colleagues. And so I think we have to be balanced when we're describing our residents and learners. So I want to show you some of the evidence that exists to show that, yes, this is an issue. So we see bias in residency end of rotation evaluations. There was a retrospective cross-sectional study that was published in Academic Medicine in 2022, and it reviewed the clinical performance assessment numeric scores from inpatient medicine rotations at 6 different US internal medicine residency programs. And race or ethnicity of the resident was associated with competency scores that were lower for URM students or underrepresented in medicine students or residents in medical knowledge, systems-based practice, practice-based learning and improvement, professionalism, and communication and interpersonal skills. Additionally, we see trends that suggest gender bias in written evaluations of residents. And so the same group did a systematic literature review that they published in the Journal of General Internal Medicine that looked at 9 studies that were aimed at evaluating for the presence of an influence of gender bias on resident evaluations. 5 of the 9 studies that they looked at did show a difference. And kind of specifically, there were gender differences in the traits ascribed to residents, like I mentioned before, consistency of feedback and performance measures. And in one study, there were significant differences in the milestone scores for men versus women. There's also evidence for bias in student evaluations. And so this was a study that was published in 2019 out of the University of Washington, and it looked at the association between race and ethnicity and required third-year clerkship grades at their institution between 2012 and 2015. And they used a multivariate ordinal logistic regression analysis that included race, ethnicity, gender, age, clerkship final score, and USMLE step score. And in doing that, race and ethnicity were independently associated with clinical clerkship grades, and specifically non-white students received lower final grades than white students, even after, again, adjusting for step 1 in their written exam score. So evaluations aren't the only things that are impacted, letters as well are. And so there was a study in 2017 that reviewed the MSPE, which is what some of us would refer to as the dean's letter that goes into a medical student's application for residency. And they looked at over 6,000 applicants to 16 different residency programs in the 2014-2015 cycle. And they found that white applicants were more likely to be described using standout words such as exceptional or outstanding compared to non-white applicants. Black applicants were more likely to be described as competent even after controlling for step 1 score. And then when the researchers pulled out the sentence that was preceding the use of the word competent, they found that it was used in a positive way 57% of the time for white applicants and only 37% of the time for Black applicants. So furthermore, the trend continues into residency and letters that we write for residents. So this was a systematic review that was published in 2021 in the Postgraduate Medical Journal, and it reviewed studies that assess gendered language in medical reference letters for residency applications as well as medical faculty hiring. And 7 of the 11 studies found significant differences in gendered adjectives between men and women, with female applicants more likely to be described using communal adjectives, while men were more likely to be described using agentic descriptors. And some of the studies showed that the letters of recommendation for the women specifically had a lot more references to their personal life, more doubt raisers, and more comments about their physical appearance or their dress. Additionally, 2 of the studies found that the letters of recommendation for men were longer than the letters for the women. So now that we hopefully recognize that there is bias in our evaluations and our letters of recommendation, what can we do about it? So I think it's important to actively reflect on the words that you're using to describe the person that you are writing a letter for or doing an evaluation for. And think to yourself, would I use these same terms if I were writing about a white male? It's okay to use communal traits to describe people, because again, we want physicians who are able to communicate and are patient and kind and approachable, but we have to make sure it's balanced, and we have to make sure that we are using standard terminology when we're describing both men and women. There are apps, there are websites where you can actually plug in the body of your letter, and it will look at it and analyze how much gendered language you're using, how much communal versus agentic language you're using to help you. And it's always good for letters of recommendation, especially to have somebody else look at it and just give you their opinion. So wanted to just share a few more pitfalls that you want to avoid as you're writing letters of recommendation. So avoid gendered language. And what does that mean? So think about these 2 statements. She is an insightful woman, or she is an insightful physician. They convey 2 very different things. And so avoid using that gendered language. Don't say woman, don't say man, use something else. She was a delight or a treat to have on service. I doubt most of us would say the same thing about a male resident. It just is not the type of terminology that most of us would use. And so if you wouldn't say it for a male, please don't say it for a woman. Be careful that you are not describing males based on their knowledge, skills, abilities, and talent, and then talking about women based on their effort, their hard work, their personality, their interpersonal traits. Avoid stereotypes. So, and especially, he performed well, especially considering he was the first in his family to attend college. And you might think that actually sounds positive, right? Like you're giving this person a lot of credit because they had to overcome a lot of obstacles. But what that reads as is they did great for someone who had to overcome those obstacles. It would sound differently if you said that he performed well. I think that there's a difference. And so try to keep those things out of your letters. Or as is common in his culture, he was quiet and studious. Please don't perpetuate those types of stereotypes. Hedging, avoid hedging. So what is hedging? This is lukewarm comments when you don't feel like you can use superlatives like outstanding or amazing. And it can kind of feel a little bit like there's caution or hesitance. And so, although Sarah has not done this type of research before, ... So that again injects some level of doubt or negativity, and you don't need it, right? You can say, skip that part and just start with, Sarah received 2 NIH grants during her tenure at the institution. It sounds better, right? Than when you put, although she had never done this type of research before. It introduces doubt. Again, try to stay away from potential negatives. So he performed adequately, or she showed improvement. It's okay to write about improvement, but sometimes we have to be careful, because sometimes that feels like coded language to someone reading it, that they were really terrible and needed a lot of coaching, and makes the person wonder if they're going to be a good fit. And then be careful of faint praise. So he will make a fine resident, or I have confidence she will be better than average. So try to stick to things that you can really say positively. And if you can't say something positive, don't say something faint praise, because it does come across as negative. So just a few other pearls before we wrap up. It's always better to highlight accomplishments instead of effort. And so instead of saying that she was hardworking and got along well with others, you might say her written and oral presentations were thorough, she was responsive to her patients, and her interactions with staff were always professional. Be mindful that you are not using superlatives exclusively for males or white trainees. And so these would be words exceptional, outstanding, superb, stellar, successful, skilled, knowledgeable, insightful, resourceful, competent, ambitious, intelligent. Be consistent in how you name residents or students when you are writing letters of recommendation. So make sure that you're not inadvertently using the title and surname for males and first names for females. And that's why when we write our program letters of recommendation for all of our residents who are going into fellowship, we use doctor surname for everyone, because we want to make sure that that is conveyed. We don't want to use the first names for our female residents. In general, again, avoid personal information in letters of recommendation, particularly if it's not relevant, and most of the time it's not. So don't say, despite having 3 children during residency, she was always on time, she stayed late, she was able to take care of her patients. Again, when you introduce that beginning of despite having 3 children in residency, you're introducing some doubt, and you're making it sound again like, she did really great for someone who had 3 kids during residency, but imagine how she would have done if she didn't have 3 kids in residency. And you don't want to put that doubt into the person's mind. So just leave that part out. And lastly, be mindful of length. Some of the studies, again, have shown that letters of recommendation for men are longer. And so try to make sure that you're saying enough about the women that you're writing letters for so that it's not too short. Okay, so you have written a first draft of your letter recommendation, and it says, "It is my pleasure to write this letter of recommendation in support of my wonderful resident, Jane Doe. I worked with Jane on my inpatient service where I served as an attending physician. Jane is a delightful person, and it was a pleasure having her on our team. She did a fine job with patient care, and she performed as expected for her level of training for the most part. She was professional in her interactions with others, was dressed appropriately, and always on time. Her patient presentations were good, and although she is shy and soft-spoken, she was very articulate. On an interpersonal level, Jane seems personable and compassionate. She was always kind and thoughtful in her interactions with others. On several occasions, she brought cookies for the team that she had baked, which was very much appreciated on days when the census was high. She has a warm personality and a kind smile that make patients trust her." I have read all of these things in letters of recommendation over the years as a program director or associate program director interviewing for residency. So these are not, and this is not outlandish. We see this all the time. And so I highlighted in red just some of the things that you maybe shouldn't say. So please don't call Jane delightful. If you wouldn't call John delightful, then don't use it for Jane. You said that she did a fine job. That's kind of faint praise. You said she performed as expected for the most part. That's introducing some hedging or some doubt, and it's also faint praise. She dressed appropriately. Please do not comment on how trainees are dressed. Although she is shy and soft-spoken, she was very articulate. You're hedging. You're also stereotyping there. She seems personable and compassionate. Again, that's introducing some hedging. Is she personable and compassionate, or is she not? She brought cookies for the team. I think it's great. We love that, but that perpetuates stereotypes and really paints a picture. And so please leave that out of letters and evaluations. And overall, it really focuses on communal traits. And again, that's not a bad thing, but was there anything else that she did well? Did she, was she a strong resident? Was she knowledgeable? Was she a leader? Was she confident? Look for those sorts of things. And I do think that sometimes, again, with our implicit biases, we notice those more interpersonal traits about women when we're working with them. We notice some of the more leadership skills among our male trainees. Sometimes that's just unconsciously what we're paying attention to. So really challenge yourself to look for those other things about your women trainees. Okay, so I want to end by saying we probably can't eliminate our implicit biases, but we can recognize them, we can acknowledge them, and actively work to mitigate their effects. So it starts with knowing what they are. So please, I encourage you to take some time to really reflect on what your biases might be. Slow down when you're making decisions and actively ask yourself if you would do the same thing if the patient or learner were a white male. I do this on rounds when we're taking care of patients and we're treating pain in a patient with sickle cell. I leave the room and I think to myself, would I treat someone who was white the same way that I treated this patient? And really kind of challenge myself to make sure that I'm not under treating their pain. It's important to self-reflect and identify ways that we can improve. Growth is a good thing. And I think one of the other ways to try to overcome these implicit biases is just surround yourself with a diverse group of people. And it helps to break down those unconscious biases and those stereotypes that you have in the back of your mind. So summary and take home points: implicit bias impacts how we care for patients. It also influences how we treat our colleagues and our learners. We need to engage in active listening and identify microaggressions, address them in real time. And lastly, we need to take steps to ensure that evaluations and letters of recommendation are free of gendered or biased language. So I just want to acknowledge the internal medicine and MedPeds program leadership teams, especially Dr. Gordon and Dr. Bishop, who have done a lot of work on this, and especially Dr. Cook, who has kind of partnered with me to try to create this curriculum that we have. So thank you. There's maybe 1 minute left, so I don't know if anybody has questions.
So thank you very much. It's really not easy to stand up in front of people and say what your own implicit biases are. I've done it. It's not easy.
Yeah.
Lots of respect there. One of the things that I've been most impressed with is that how this can change residency evaluations and medical school admission to try to improve what we have as a pipeline, which you pointed out is such a need. I guess I talked about my older daughter last time, so I'll talk about my younger daughter this time. She's a program director at University of Illinois, and before I gave my last talk on implicit bias, she actually sent me her slide. She had a couple concepts that I hadn't considered before. One was having this is for child psych residency. The idea was to take all the applications in with no pictures and no scores. And that meant I'm just trying to process that. And while it may, at one level, decrease the amount of bias, it increases the dependence on letters, which you just told me are pretty bad.
Yeah.
And so what is it that you're employing in our program to try to, obviously no pictures, no scores is really kind of hard. So what is your best solution to try to shield us from our own implicit bias?
Yeah, that is a great question. I think for us, we have tried to really be intentional and active in our thinking about applicants. And so when we look at applications, we do kind of think about, is is this a woman? Is this someone who's underrepresented in medicine? Really trying to make sure that we're not biased against them. I think we still use step 2 scores to an extent because I think everybody does. It's unfortunately the only objective marker that we have as to whether someone can successfully pass boards. And like I've mentioned here, the MSPEs and sometimes the letters of recommendation are really not helpful. But we also don't use that as our only criteria. And so I think that we really try to look for activities and community engagement and involvement, and really try to push ourselves to not rely on scores and not, it all goes into sort of a big bucket. But we do go back through evaluation or back through the applications again and really try to make sure that we have not overlooked people, particularly those who are women or underrepresented in medicine, because we know that there is that tendency that we might overlook them and pass through them. Hi.
So one comment I have is, especially during the pandemic, and I tell this for the students and the residents all the time, everybody's into scouts and not everyone wears their white clothes anymore, is to keep your ID on. Sometimes at the VA, especially, not the patients, especially somebody there, or that somebody walks in the room, they will tell me this stuff, I don't know who they are, I know them, I don't know them. So, I just sort of insist that we do our part to also make it easier on the patients.
Yeah, absolutely. So for those that didn't hear, make sure that you're wearing your badge, especially now that many are not wearing their white coats. Wear your badge prominently so that patients and others know who you are, and know that you are a physician or a student or part of the team. Good. Well, thank you. I again, it was exciting to be here, and really looking forward to a new season of Grand Rounds and hopefully more in person.